Welcome to AETCM, the emergency medicine channel. Today we are going to discuss regarding disseminated intravascular coagulation, that is DIC. Disseminated intravascular coagulation is a hematological disorder which results in a paradoxical tendency to thrombosis and bleeding at the same time. It is also referred to as consumptive coagulopathy or defibrillation syndrome. DIC occurs in response to an underlying trigger or pathological process. Most commonly, the underlying causes are trauma as well as sepsis. We have an International Society on Thrombosis and Hematosis which mentions that DIC is highest in trauma and severe sepsis, which is around 8.9 to 28.9%. Mortality in these patients is alarmingly over 30%. As per the International Society on Thrombosis and Hemostasis, DIC is defined as an acquired syndrome characterized by the intravascular activation of coagulation with a loss of localization arising from different causes. It can both originate from and cause damage to the microvasculature, which if sufficiently severe can produce organ dysfunction. According to the British Journal of Hematology,
Understood.
According to the British Journal of Hematology, it states that DIC is a clinico-pathological syndrome which complicates a range of illnesses. It is characterized by systemic activation of pathways leading to and regulating coagulation, which can result in generation of fibrin clots that may cause organ failure with concomitant consumption of platelets and coagulation factors that may eventually result in clinical bleeding. Now coming to the pathophysiology of DIC, in normal hemostasis, vessel injury triggers localized clot formation at the site of injury, which is then followed by clot resolution, that is fibrinolysis with tissue repair. This is a very tightly controlled process within the body by regulatory proteins and feedback mechanisms. But in DIC, there is abnormal systemic activation of the coagulation as well as the fibrinolytic pathways, when blood cells and the endovascular lining are exposed to a procoagulant factor. There are multiple procoagulant factors depending on the condition, disease condition that the patient is right now suffering from.
If there is an injury inside the blood vessel,
Yes.
normally clotting factor will come and it will clump that area, it forms a clot.
Also.
Finally, after everything is healed, the fibrinolysis happens and that part is removed. But in cases where there are
triggers, triggers in the body.
Yeah, in cases of sepsis, trauma, blood transfusion, malignancy and all these things,
there are certain procoagulant factors.
Yeah, procoagulant factors will come into play.
So they will trigger the patient to go into DIC. So the triggers in case of sepsis are the lipopolysaccharides. Like any bacterial infection will have lipopolysaccharides. Then in case of meningococcal sepsis,
so if in case of a LRT pneumonia with sepsis, if there is a DIC, the procoagulant factor is lipopolysaccharide.
Okay. Then in case of any trauma, there will be damage to the endothelium, which in turn results in release of phospholipids.
Yeah. In trauma, it's phospholipids.
In malignancy, it is tissue factors produced by the cancer cells. And in blood transfusion mismatch, these are the cytokines, especially tissue necrosis factor and interleukin 1. So these are the triggers, these are the procoagulant factors.
If the wrong blood is
transfused,
what is the
cytokine? It will be tissue necrosis factor and interleukin 1.
Interleukin 1 will be released. These will induce
DIC in that patient, might trigger DIC. So there are the ISTH definition emphasizes 3 factors that lead to organ dysfunction. One is systemic thrombin generation, not restricted to the site of insult. It will become a disseminated process throughout the body. Patients will start developing thrombosis. Then there will be bleeding tendency due to ongoing activation of the hemostatic system, and then coexistence of other hemodynamic as well as metabolic derangements, all of which will ultimately lead to multi-organ dysfunction and failure. Then activation of the intravascular coagulation and fibrinolysis. So what actually happens is there will be activation of the coagulation cascade, which will lead to formation of thrombi in the microvasculature as well as the large vessels. Then fibrinolysis will start at the site of thrombus formation, and the resulting fibrin degeneration products will interfere with platelet aggregation and further fibrin clot formation. Then consumption of coagulation factors will lead to a hemorrhagic tendency. because coagulation factors are not there, it won't clot easily. Then vascular factors, endothelial damage from the thrombus or ischemia.
So basically the patient will have heavy bleeding tendency. So that is what we are supposed to prevent. We are supposed to diagnose it early.
So vascular factors, endothelial damage from the thrombus or the ischemia will result in a procoagulant release. Reduced organ perfusion will lead to reduced clearance of the coagulation byproducts. And with it, if hypothermia or acidosis and sepsis on trauma if starts, then it will start with the vicious cycle. So acidosis, hypothermia, coagulopathy.
That is the vicious cycle.
Onset will start. So what happens is, we'll start with intravascular coagulation. Fibrins will start depositing. Once fibrin deposition starts, it will start with the platelet consumption. So platelet will start falling. Fibrin deposition will also cause coagulation factor consumption. When coagulation factors are starting to get consumed, the PT and the APTT of the patient will start rising. And then fibrinolysis will start. And due to fibrinolysis, the fibrin degradation products, that is D-dimer and FDP, will start rising. So all this will finally lead to impaired coagulation and bleeding in the patient.
So what are the main things?
It is first is platelet consumption.
Platelet consumption.
Then coagulation factor consumption.
Coagulation factor consumption.
Then fibrinolysis.
So totally everything points towards heavy bleeding. Manifestations. So
these can also go to the microvascular microvessels, and then they can cause thrombus there, reducing the organ perfusion. That particular organ perfusion
and then finally
reduce.
Multi-organ damage,
dysfunction will organ
happen.
failure. Autoimmune hemolysis can also start. Then the patient will hemoglobin also will start dropping. Like hemolysis will start. So peripheral blood smear might show you cystocytes. That is like only in case patient goes into microangiopathic hemolytic anemia.
Cystocytes means damaged
RBCs.
Cystocytes. That is peripheral smear. In ER
you won't do that.
Make out. But in ICU you will get to know. You do a peripheral smear and all, immediately you will get the diagnosis.
Then regarding the clinical manifestations, we have manifestations of bleeding and manifestations of thrombosis. So DIC presents as a spectrum of pathological intravascular thrombosis as well as bleeding. It will vary according to the underlying causative disease which triggered the DIC. So manifestations of bleeding will be dermatological bleeds ranging from minor petechiae to widespread purpura under the skin. This will be the skin findings. Then excessive bleeding and purpura around venipuncture sites. Wherever we have put cannula, if we suppose remove that, patient will have unstoppable bleeding. Then prolonged external bleeding.
Even in liver failure, we will get these things. Liver failure, prolonged ITP, TTP,
similar
all
findings.
These things, similar findings you will get. All purpura, hemorrhagic manifestations over the skin.
Prolonged external bleeding, including epistaxis or menorrhagia, and occasionally only patient might go into catastrophic internal hemorrhage like GI bleed or IC bleed. Then manifestations of thrombosis.
So we can get bleeding anywhere, even in the brain and the skin.
Under the skin, GI,
GI, even the lungs, pulmonary hemorrhage,
yes.
Oral cavity bleeding, UTI, like hematuria, anything can happen.
Manifestations of thrombosis. Thrombotic manifestations in DIC are further classified as macrovascular and microvascular. If it is macrovascular, it will present as venous thromboembolism like DVT or pulmonary embolism. In case of microvascular, it will be small organs, small vessels which are damaged. So manifests as usually organ dysfunction. Like if renal involvement presents, it will present as oliguria and hematuria, might progress to renal failure. Pulmonary involvement as hemoptysis, pulmonary hemorrhage, and sometimes acute respiratory distress syndrome also. CNS manifestations, patient might go into altered sensorium, delirium, coma, and skin manifestation sometimes, which is known as necrosis of the skin like purpura fulminans. So basically to diagnose DIC, we have...
So in ER, patient can present with a wide variety of symptoms. Upper GI bleed, purpura, hematuria,
gum bleed.
Breathlessness with the hemoptysis, pulmonary hemorrhage, gum bleeding, even IC bleed. So we don't know whether the patient has got an underlying DIC or not. That we'll have to find out. Presentation will be in this way, in all bleeding manifestations.
So
then we'll have to find out whether the patient has got sepsis or some trauma or some blood has been transfused or malignancy, and then do the blood investigations to diagnose whether the DIC is there or not. So PT, APTT,
platelets, and
platelet and fibrinogen, all these things will have to be sent. Because we have got other DDs for DIC, we have got TTP, ITP, HELP syndrome, liver failure, liver disorders, and all these things are there. So we'll have to differentiate DIC from this one.
And then coming to DIC diagnosis, what we have to basically look at is the clinical condition which is associated with DIC, then the manifestations, either bleeding or thrombotic manifestations, then deranged lab abnormalities, and signs and symptoms associating with the underlying disease. So coming to lab investigations, we will look for the platelet count. Usually we will have thrombocytopenia. Seen up to 98% of DIC, usually platelet will be more than 50,000. Then coming to PT, APTT, they will be usually prolonged. Around in 50 to 60% cases, usually APTT, PT-INR will be prolonged. Then coming to fibrin degradation products and D-dimer, it should be raised. This is a non-specific test, but if you do it, it will help aid in your diagnosis. Then fibrinogen should be low, but around 57% of patients can have normal fibrinogen also. Then we can go ahead with thromboelastography, that is TEG.
So basically platelet
will reduce,
PT,
APTT, PT will increase, fibrinogen should be low or sometimes can be normal. FDP should be high. Then TEG we can do if we have the facility.
Thromboelastogram.
There's
something called as thromboelastogram.
So it will typically show hypercoagulability during early DIC and hypocoagulability during fulminant DIC. In early this thing, it will be hypercoagulable. Later, it will go into hypocoagulable state. Then we can do blood smears for looking for schistocytes. When we have a scoring for DIC, it is the International Society of Thrombosis and Hemostasis. ISTH has developed a scoring system. So here the parameters are platelet count, PT, fibrinogen, FDP or D-dimer.
DIC score.
DIC score. So each, like platelet count, we have each category has a score of 0, 1, 2. Just D-dimer has a score of 0, 2, 3. So according to the levels, we need to score, like platelet more than 100, less than 100, less than 50,000. Like the 0, 1, 2 will give the scores. And if the score after calculating each parameter comes to more than 5, it is over DIC.
The cutoff is more than 5. So you can use that, Google, you can get that MD Calc app is there. That you will get the DIC score. You can calculate if the cutoff is more than 5, means
it is over DIC. The scoring system has a sensitivity of 93% and a specificity of 98%. But we should have DIC and we should have a precipitating cause to apply this scoring. Then coming to differential diagnosis, we have around 2 to 3 differential diagnoses for DIC. It could be like we have to differentiate between, like it could be immune thrombocytopenia, it could be coagulopathy in acute liver failure, it could be thrombotic thrombocytopenic purpura, or it could be HELP syndrome. So the difference in each will be if it is immune thrombocytopenia that we are suspecting, then it will idiopathic.
Immune thrombocytopenia or idiopathic
thrombocytopenia. It can be primary or secondary, but usually it will have isolated thrombocytopenia only. PT-INR, APTT or fibrinogen, these all won't get affected. Only isolated thrombocytopenia with a normal peripheral smear is primary ITP. If secondary, we will have other etiologies like HIV, hepatitis, SLE, leukemia, or any certain drugs causing ITP. Then in case of coagulopathy in acute liver failure,
that is the importance of taking a past history. That the patient has got some SLE, HIV, what are the things?
HIV, hepatitis C, leukemia, SLE,
drugs. That's the importance of taking drug history also.
Then coagulopathy in acute liver failure. In acute liver failure, we have around moderate reduction of platelets, secondary to splenic sequestration, bone marrow suppression, or decreased thrombopoietin production. So here also patient will be having reduced platelets and sometimes INR might get rearranged.
Here the pathology is different. In liver failure.
It is due to decreased production of vitamin K dependent clotting factors, that is 2, 7, 9 and 10. With that, patient will have other features of liver failure like clubbing, palmar erythema, gynecomastia, testicular atrophy, small liver, asthenia, anemia. Then coming to thrombotic thrombocytopenic purpura, it is basically caused by a decrease in activity of von Willebrand factor. Von Willebrand factor cleaving enzyme, that is ADAMTS13, ADAMS 13. So if it's a deficiency in that, it will lead to TTP. So here also patients will usually have it will be problem in platelet aggregation, and there will be diffuse thrombus formation in the body with decreased platelet counts. Then coming to HELP syndrome, which is usually seen in pregnancy.
What is the TTP? What is the reason behind TTP?
AETCM 13.
13. Fracture cleaving.
So then coming to HELP syndrome, it is hemolysis, elevated liver enzymes and low platelet count syndrome. It is hallmark of an obstetric condition where hypertension, deranged liver function test and thrombocytopenia.
HELP syndrome.
HELP syndrome.
Heard about it?
Usually associated with preeclampsia. HELP syndrome will
Hemolysis,
not cause
elevated liver enzymes,
liver
low
enzymes
platelet
will be
count.
and low platelet counts and hemolysis. Usually HELP will not cause APTT, PTN derangements. So if we want to differentiate between all these, in DIC platelet will fall, PT, APTT will rise and fibrinogen will be normal or low. In ITP only platelets will be low, whereas the other three will be normal. TTP also only platelets will be low, other three parameters will be normal. In liver failure, platelets will be low, PT, APTT will rise and fibrinogen will be normal or higher. And also we can
So liver failure and DIC
is opposite, last fibrinogen.
Yeah, last
can be
fibro,
used.
that is the thing. All other parameters in liver failure and DIC are almost the same, except for fibrinogen. One
Fibrinogen is
will
low,
be
DIC.
in DIC, the other one it will be
High. Then another one is heparin induced thrombocytopenia. Their platelets will be low, PT, APTT will be high and fibrinogen will be normal. So here also same, but only fibrinogen won't get affected.
yes. So fibrinogen is the one thing
Which is differentiating all these conditions.
catches makes the diagnosis of DIC.
DIC. Then the treatment of DIC can be broadly subdivided as you have to take measures to treat the cause. Then we have to start with any blood transfusions, whatever is required according to the blood parameters that
Basically,
we
DIC
get.
is a syndrome
Yes.
which can happen in a variety of life-threatening
Diseases.
situations.
Then specific treatment comes to any blood products or derivatives, any antithrombotic drugs, that is anticoagulants, and antifibrinolytic drugs, that is tranexamic acid. So what all transfusions that are recommended? If there is significant anemia, like if there is hemoglobin less than 8 in non-cardiac patients or hemoglobin less than 9 in cardiac patients, we have to start blood transfusion. Then in case patient is having active bleeding with a
What is the
platelet
cutoff for this thing? Blood transfusion?
8, less than 8 in non-cardiac, like no cardiac history patients, less than 9 in cardiac history patients. Then in case of platelets, if patient is having active bleeding with a platelet of less than 50,000, we have to transfuse platelet. If patient has no active bleeding but platelet is less than 30,000, you have to give platelets.
If platelet is less than 30,000, anyway you'll have to transfuse. But if the platelet is less than between 30,000 to 50,000,
and with active bleeding,
yeah, with if there is no bleeding, no need to transfuse. But if there is a bleeding, if the patient platelet is between 30,000 to 50,000, transfuse.
Then there is active bleeding, and we have to see the APTT-PT ratio. If that is less than 1.5, we have to give FFP. Dose of FFP is 15 ml per kg. Then if there is severe hypofibrinogenemia, that is less than 1 gram per liter, we have to give fibrinogen concentrate or precipitate, cryoprecipitate.
So we are not checking for INR here.
Yes.
Got it, no?
Treatment doesn't.
We are not looking at INR here.
Then coming to anticoagulation treatment, that is heparin. This heparin is done, dosing is done only in thrombosis dependent predominant DIC, that is in early phase when thrombosis starts. In that time only we can give heparin. Usually preferred is intravenous unfractionated heparin, as it has a short half-life and it is reversible. IV unfractionated heparin.
UFH is the treatment. Okay.
Prophylactic doses of UFH or low molecular heparin are recommended in critically unwell or non-bleeding patients. We can give. Then another one is antifibrinolytics, that is tranexamic acid. It is given in severe bleeding with hyperfibrinolytic states. Basically, in DIC, we can give Tranexa and other blood transfusion, but IV heparin in early stage only, in thrombus.
Yeah, that is
thrombotic
one
stage
thing to
only
be
we can
noted.
give.
Only in early stages you give. Late stages of DIC you don't give unfractionated heparin.
That is regarding the treatment.
And treat the underlying cause of whatever
Underlying cause has to be managed.
this is sepsis,
Sepsis, trauma,
some antibiotics or whatever it is, you'll have to.
pregnancy, anything.
That's all. Anything? Any questions? Can I ask? That's all. Okay. Thank you.